This is good. Lovely. So we're just going to leave it. I've got 6:59 on my clock at the moment. So we're just going to leave it a minute or so as the numbers tick up, which we can see. You can see it was 7 o'clock in the UK here. The sun is shining, as it always is, very rarely. We're really excited about this talk tonight. And I'm going to just talk a little bit at the beginning of the talk, just to talk about why we're here. I'm very excited about this talk in particular because neuro exam for me when I was in practice was one of those things that I was sort of comfortable with, but it was when to apply it, how to apply it, and then how to start to interpret it in that clinical setting as well. So, and it's a simple skill and a real skill to have. But and I've seen Anna's slides. I'm really interested in what she's got to say tonight. So that's fantastic. Okay, great. Anna, do you mind just moving the slide on a second? Okay, so my name's Richard Artingstall. I'm Director of Teleconsulting at VetsCT. So this is specialist case advice. So we help you with any sort of case that you will see in clinical practice. And that's what we're here to talk about today. But VetsCT as a company is a global team of over 200 specialists. And essentially, we're just here to help you. We specialize really in, of course, exceptional radiology. So that's CT, MRI, ultrasound interpretation and radiographs. And then the side tonight, which we're going to be talking about, and Anna's part of the neurology team here at VetsCT, and this is the specialist case advice or specialist advice service. And we also have an education service as well, where we work with universities around the world, promoting resident education and undergraduate education, and just trying to be sort of that beacon of light in the veterinary industry that people know VetCT for, because we're a really lovely company to work for, and we've got really good values that we want to help the veterinary profession. So I'm just going to promote the written specialist case advice just briefly while we've got everybody here. Essentially, what we provide is written advice to you to treat cases in-house. We have really fast turnarounds times, so you can pretty much rely on us to be there in 12 to 24 hours, often sooner in a lot of cases. And that's in multiple disciplines as well. So we've got 11 different disciplines. And one of the unique things about us is that we offer unlimited follow-ups on a case. So we're all clinicians. We all understand how clinical cases work in practice. And actually, when you generate a case, it isn't just a one question and then go away. We're here to help. We're here to support people and collaborate. And we really enjoy that part of it. And it's actually quite a fun way of working. And when you use it in practice, you'll see it's quite a dynamic way of working. So we use these follow-ups to sort of help people through the case. What we end up with essentially is detailed notes that you can add to the file, detailed notes that you can share with clients, and very soon we'll be producing sort of formatted results as well that you can actually share and collaborate with as well. What we do find is that clients are absolutely delighted to stay with you guys in practice and in the centres that you're at, but also they're really, really delighted to have that specialist on your shoulder as sort of an extension of your team. And that's what we are. We see ourselves as an extension of your team. But they really like to stay with the vet that they know and trust for cases that are suitable to be kept in-house, of course. For you guys, we give clear and detailed next steps. We really help with reducing uncertainty. So a lot of the advice we give is actually just sort of reassurance advice as well. Yep, you're on the right track. I would tweak this, I would do something here, or here's my tips here. The way you can use us is through the desktop. So if you go to VET.CT.com and you can then access our platform through that, or if my blur stops, we've got an app in the Play Store and the Google Apple App Store as well. And I would suggest that you download the app. It's a really, really dynamic way that you can access our services. You can dictate into your phone. If you've got a practice tablet, you can use that. You can take photos, you can take videos, you can upload documents, you can do all sorts. And I think for neurology as well, I'll just come on to neurology in a minute, multimedia sort of input to us is really, really, really useful. So videos, sounds, photos, anything like that. So actually our digital technology now is really, really useful for neurology as well. You can use us on a pay-as-you-go basis, a case-by-case basis. So just literally, if you just wanted to use us once, you can do that. Or for practices or individuals that want to start to build that relationship with us, we offer subscriptions to our services as well. So it's a really exciting new way of working, and we're here to help you. And if you would like a demonstration webinar, or you want to know a little bit more about us, first of all, scan this QR code. But if you would be interested in a demonstration webinars or a talk-through or walkthrough, just contact me directly, richard.artingsall@vetct.com. So yes, so next slide if we can, please. So just a bit of housekeeping today. This is going to be recorded, so everybody in the talk or who's registered for the talk will get a link to the recording pretty quickly after the talk, so it normally comes through pretty quickly. There is a Q&A box at the bottom. If you think of anything or you want any questions, we're going to have Q&A at the end. So to pop the questions in there, and I'll ask the questions to Anna, and then we can just sort of have that dialogue as well. Everybody's going to be on mute for this. It's automatically on mute, so you can't sort of put your hand up as such. So yeah, so we're going to get to the talk now, and like I said, neuro exam for me is a really vital part of almost every clinical exam that I felt I had to do in practice, because once you understand the sort of the tips and tricks which Anna's going to go through today, I think this is going to enable you to build this into almost everything that you do. Like I said, Anna's one of our team of neurologists, and we're very excited to have a central part of our team. So Anna, I'm going to hand over to you. I'm going to stop talking, and then I'm going to enjoy this. So thank you.
Thank you so much, Richard. So welcome, everyone. I'm really excited to have so many people here today with us. Today, the learning objectives are to understand all the stages of a complete neurological examination, to interpret and to be able to differentiate between a normal and an abnormal neurological examination, and to know the difference, especially between dogs and cats, when we are performing neurological examinations. However, and especially based on the format that we are doing, that we are going to have like a short talk and then a long time to ask for a lot of questions, I want to give you this talk a little bit differently, that probably you've seen it before. So as Richard was saying before, we probably almost all know how to do a neuro exam. You've seen it in books, you've seen it in other talks. And what I wanted to give you is an insight. It's the 10 top tips that I wanted to know at some point, but I've learned just with time and with experience. And what are the things that I spend more time, and what are the things that I wish I would have known sooner? So I hope that this format it's suitable for all of you. So let's start from the beginning. And tip number 1 would be, in case of doubt, do a neuro exam. Why and when do we do neuro exams? We do neuro exams to decide if there is a neurological problem. If there is a problem, where do we localize this problem? And if we know there is a problem and we know where to localize it, then with the history, with the clinical signs, with the general physical exam, the neurological examination, and putting everything together, we will be able to create a list of differentials. It's important that you understand that a neuro exam is just a part of an exam, and it's something you can do in any animals. And I will say that maybe 1/3 of the neuro exams that I do in my clinical settings are normal, and it's just some friends and some colleagues just telling me, I'm not completely sure, can you check, is that neuro? And then when we check, the answer is no, I don't think that it's neuro, or I would recommend just like going through other things first rather than starting from the neuro part. And that's okay. So in case of doubt, or if you don't really know if there will be a neurological problem, just do a neuro exam. How to do a neuro exam? The neuro exam has 2 main parts. What we call the hands-off, that it's a part that we are only going to have a look at the animal and we are not going to touch it. And then we have the second part, that it's the hands-on, the manipulation. The more I learn and the more neurology we know, the more time we spend with the hands-off than with the hands-on. And that's something tricky. It's tricky for different reasons. Number one, it's because in first opinion, you don't have a lot of time to do a consult, and it's not the time that we have like a specialist in referral practices. And I then understand that that makes things tricky. And number two is that when I started, I felt like a lot of pressure for the families looking at me, trying to wait and expecting for me to touch the animal and do things with the animal. And that's fine. And that will come, no worries. But a neurological consultation starts in the waiting room. The way that the animal is sitting, especially dogs, of course, but the way that the animal is sitting, the way the animal is standing, the way that the animal is walking. And in all the clinics where I work, I always try to have the consult that is more far away from the reception. And I always try to use that one. So while I just go there, I present myself, and then we said, oh, let's go to the consult, I have the full corridor to see how the animal is walking. The hands-off examination has three parts: has mentation and behavior, posture, and gait. But as we will see in a second, that's just what the book is saying. And at the end of the day, there's a lot of information from the hands-on that we can get just looking at the animal, and I will show you later. The hands-on has different parts. Has the cranial nerves, proprioception, segmental reflexes and muscle tone, and sensation. And the more you learn neurology, the more time you should be spending here. Let's go one by one. The number third is that mentation and behavior are not the same. This is a drawing of a brain, and in the brain we have like three main parts. In blue, we have the forebrain. In green, we have the brainstem, and this is the cerebellum. And there is a structure that is quite big and diffuse that it's called the ARAS, the ascending reticular activating system. The ARAS is the responsible especially for our mentation, but the behavior, it's more important in the hemispheres. When we do a neuro exam, there are four mentations that we need to be aware. Alert, that is an animal that is responding to the surroundings. Obtunded, that the response of the surroundings is less than expected. Stupor is an animal that is not responding to anything except pain. And coma is an animal that is not responding to absolutely anything. The more we have, like the worse mentation we have, like especially for stupor and coma, the more likely that the ARAS is affected. And when we talk about mentation, we only have these four options. However, you will tell me, yes, okay, but not all the animals are the same, and then there's like animals presenting in a lot of different things. I agree, but that's what we call behavior. The behavior is how an animal from the same breed age will interact with you in the same environment. And that could be tones of things, could be quiet, anxious, disoriented, could be friendly, could be like tones, like there will be like a lot of different behaviors. And of course, this behavior is important. If we have a really aggressive animal, maybe we are not able to do a complete neurological exam as we want to. But we need to make sure that these two things are independent. Therefore, as a summary, when we talk about mentation, we talk about the quantity, how much the animal is responding. And when we talk about behavior, we talk about the quality, how the animal is responding to these surroundings. So if we look at that, we can have a look at this dog and see that just in the consult, we can see a lot of things. We can see a dog that is alert. It's alert of everything that is happening, but a dog that it's friendly, that it's following us, and that is trying to see what's going on. And these two things would be completely independent. The advice number 4 is that we move to the posture. And the posture is extremely important. And the posture can give you the answer. So spend time learning all the postures. and spend time understanding where to localize the postures. The postures, it's a picture. The posture is how the animal is against gravity. And it would be just a picture with the animal not moving. The reality is that, of course, the animals are moving around. And therefore, we cannot stop them completely. But we need to assess them in the more normal position that we can. When we examine the posture, we will be looking at head and neck, body, and limbs. And we can do one by one independently. When I'm saying that posture can give you the answer, is that it means that the posture can help you a lot localizing. And for example, this is an animal with a head tilt. That means that one ear is lower than the other one. And head tilt, we know that we localize in the vestibular system. So just looking at this picture, we know that this animal has a problem in the equilibrium. And this, it's not the same as head turn. This dog has both ears exactly at the same level. Remember the previous one, the head tilt, one ear was lower than the other one. This one, both ears are at the same level, but the head is rotated. And it's what we call head turn. The head turn is localized in the prosencephalic area. So just looking at the dog, we know that there is a problem in the prosencephalon, and we know, or in the forebrain, that is the same. And we know that the problem is on the left side because it's always ipsilateral to the same side of the lesion. If we have a look at this picture, this is called pleurostotonus. Pleurostotonus is exactly the same as the head turn, but instead of just turning the head, turning the full body, and we have like this C posture. The localization is the same as the head turn. It's a forebrain lesion, ipsilateral to the same side where the lesion is. So just looking at this dog, we also know that we have a right forebrain lesion. Another one, head pressing. Head pressing would be an animal that just like stays in a corner or put the head like towards a door or towards like the wall or something like that. And it's another sign of forebrain lesions. So if you look at all of these ones, just looking at the picture, we already know a lot of information. And that would be this hands-off I was talking about that we need to pay attention. If we move, and instead of looking so much to the head, we look a little bit more to the neck, we would have this picture, that it would be a low head carriage. This dog, and of course, here we would need to see the dog moving, but has the neck really, really stiff and really lower down. See how the back is looking. And this is a sign of neck pain. A little bit different, we have neck ventroflexion. Rather than having a really stiff neck, the neck here is really weak. As I said, just looking at the picture, it may be really difficult to have a look. But when we are examining the animals ourselves, is when we need to pay attention to these things. Neck ventroflexion, cause number one, really far for the other ones, are potassium problems, hypokalemia. So just looking at this cat, we may know that we need to check how electrolytes look like. Other postures, kyphosis, that would be this back, so going up with this posture, usually related to back pain. Sitting posture, an animal that cannot walk and really stiff of the pelvic limbs, really common of T3L3 lesions. And this was a dog after surgery. Knuckling, one limb just completely turning down. It means that there is a proprioceptive deficit. Or another example would be a plantigrade cat, where number one diagnosis, differential diagnosis, would be diabetes. So a little bit of a summary of this slide is to say the posture can give you a lot of information. And of course, for this cat, for example, diabetes is not the only cause of a plantigrade stance, but the posture, it's going to give us the most important part of the neurological examination. So I really encourage you to look a lot of the postures and try to learn the neurolocalization of these postures as much as you can. Number 5 would be the gait. And for the gait, I know a lot of people that get really, really stressed and they see the dog walking or the cat walking and they don't know where to look at. My advice, when the animal is walking towards the opposite side, look at the pelvic limbs. And when the animal is coming back, look at the front. And then look each limb independently. When it's coming back, just look at the front. When it's leaving, just look at the pelvic limbs. And then after, you will put everything together. When we are looking for a gait, we need to check only 2 things. Ataxia, that ataxia is coordination, is the ability for one limb to be predictable, to know where the next limb will be, and motor function, that it's weakness. Ataxia is this incoordination, and we have 3 types of ataxia: proprioceptive, vestibular, and cerebellar. Proprioceptive, more related to spinal cord problems, vestibular with vestibular system, and usually the animals will fall to one side, and cerebellar, we will have intention tremors and other kind of wide-based stance and not being able to move that much. Motor function. There are 2 concepts that are really, really important. Paresis, that we have a decreased movement. These limbs are not moving as much as we wanted. And plegia, that are not moving at all. When the animal is moving less than normal, is when we can classify it if the animal is walking. And by walking, we usually decide 10 steps, being able for the animal to do 10 steps on her own or on his own. And non-ambulatory is when the animal cannot do 10 steps. When the animal cannot move at all, and only in these cases, we will check deep pain. And we will try to see if they can feel and can feel what we are doing, and especially in the limbs. And we will classify it with deep pain positive or without deep pain or deep pain negative. So we go back to number 2, and we said spend time with the hands off. And if we have a look at this video again, we know mentation is normal. Behavior is quite friendly. The posture, it's true that we cannot stop the dog, but it looks quite normal. And we can assess the gait, and this gait is really, really normal. But not only that, there's a lot of information that we can get from this video. Is this dog blind? No, it's really clear that this dog can follow us and can see what we are doing. If we make noises, the dog reacts. Therefore, the dog can hear. If we look at the face, there's symmetry. So there's a lot of information that it's not on the textbooks, and it's not on the more hands-off normal part, that if we spend time looking, it's really, really likely that we can get more and more and more with time. So if we move to the hands-on, the first thing that I would suggest you is that you decide what goes first. In the hands-on, there are 3 different parts. There's cranial nerves, proprioception, and reflexes always go together. So you should always do proprioception and then reflexes. And then the last thing will always be sensation, trying to assess if the animal is painful or not. What to choose? There's a lot of people that always ask me, and what do you do first? Do you cranial nerves or do you proprioception? It doesn't matter. You can do whatever you want and you can choose. And you need to find what works best for you. There are some people that prefers to do always the same order. If you ask me what I do what I think that it's going to be most important first. So for intracranial cases, I always do cranial nerves first. And for back problems or peripheral nervous system problems, I always do proprioception and reflexes first. And the reason why I do it like this is because if the animal becomes aggressive, if for any reason I need to stop doing the neuro exam, or I need to make it as short as possible, I already got as much information as I wanted. And sensation always the last thing. So when we do perception, there are two things we need to choose: where we do it and which test do we decide. For dogs, I always recommend you to do it on the table. And there's a massive, on the floor, And there's a massive difference between doing it on the table than on the floor. And I can tell you that on the floor, like, the animals are much more relaxed and proprioception will be much more reliable. The rest of the neuro exam too, but especially proprioception. In really small dogs, Chihuahuas, Yorkshire Terriers, and cats, you can use the table because they are much more used to going to the heights and they are much more used to be in that situation and be much more relaxed. But if you can, always try to go to the floor. To do proprioception, look at this hand here. It's really, really important that we have the animal in standing square position. We hold the body weight, we position the limb, and we can do just paw replacement. And really, really gently, this arm, it's going to drop the weight and see what happens. See this case. If I'm not putting the weight, proprioception seems normal. If I'm holding the weight, proprioception is clearly abnormal. So positioning these animals and holding the body weight, it's really, really important in these cases. For me, in dogs, try to do as much as you can paw positioning, and it's going to be one of the easiest one. And in cats, I strongly recommend doing hopping and try to do it a little bit fast if you can, because they can get like a little bit stressed. And I just try to hop them in all four limbs and try to assess them as much as I can, trying to make sure that it's something fast, but not bothering them, or trying to decrease the stress as much as we can. After proprioception, we will do reflexes. And for the reflexes, at least do withdrawals. There's a lot of reflexes, and all the reflexes, of course, are important. But withdrawals in both thoracic and pelvic limbs are the most important one. And the reason why are the most important one is because they will take all the information from all the segments. Therefore, if you check withdrawals in the thoracic limbs and in the pelvic limbs, and they are normal, then you will have very likely all the reflexes that are okay. If withdrawals are abnormal, then you may need to spend a little bit more time trying to understand which part is not working properly. If you have time, and especially in back problems, I also recommend to do the cutaneous trunci, that it's going to be really, really helpful to try to localize where the lesion is. For cranial nerves, the best tip I can give you is that less is more. In this table, I put all the cranial nerves we have, and I put how to examine each cranial nerve. My recommendation, as much as you can, is always go from behind and try to hold the animal the less possible. The more you go to the mandible, the more you try to close the mouth, the more the animal will move and uncomfortable will be. If you try to hold the animal more like going to the neck, and if you try to go from behind, they are going to be much more relaxed when assessing the nerves and going to be much more comfortable. One thing that I do, like especially in stress animals, is that they are looking at their families, and then the families are there and the families are touching them, and I'm just behind trying to do the testing. And I can tell you that this has been like quite life-changing to try to make sure that they are as comfortable as possible. Number 10 is sensation. And for sensation, there are 4 concepts that you really need to understand. Pain is a word that we all use. However, it's true that we shouldn't be using it that much, because pain is a subjective sensation, and it's really difficult to know if the animals they really have pain or not. And the example for that is that each of us with the same stimuli, we can have different thresholds, and we can be, some of us really, really painful and the other ones not painful at all. The terms we want to use, and the most important one, is hyperesthesia. Hyperesthesia is an extreme reaction, or a reaction that is higher than expected for something that shouldn't be painful. When we are palpating the whole back, that should not be painful. And we need to be aware that we shouldn't be pressing that much. If the animal reacts, then that's what we call hyperesthesia. And you will see that in a lot of our, on our reports and everything like that, that it's the correct term to refer to pain. Hyperalgesia, that is another term that you may hear, is an extreme reaction, but the difference is that the stimuli that you are giving, it's really painful. And that's the reason why we give analgesia. We give something to try to have no stimuli to pain. So hyperalgesia should be something that we shouldn't be using, because we shouldn't be causing that much harm to the animal to have hyperalgesia. Instead, just a gentle movement and palpation of the back, and see if there is a reaction that we will be not expecting. Nociception. Nociception, it's when we assess deep pain. And it's really, really important that you understand the difference between nociception and a reflex. In this dog, that's a reflex. And basically what I'm doing is that very, very gently, I'm pressing between the fingers, and I'm very, very gently and fast addressing and making a reflex. I will just put it again. And now, that's a reflex again. And now I'm pressing really hard. This dog was a dog that was deep pain negative. And now what I'm doing is that I'm pressing really, really hard. Instead of pressing in the middle, I'm pressing in the digit, and as you can see, there's no response. The animal is not feeling absolutely anything. And this nociception, we will only do it in animals deep pain negative. One of the most common mistakes, or the most common things we see in our examinations, or we see in cases that are referred, it's an animal that is ambulatory or that has non-ambulatory paraparesis, deep pain negative. And that's one of the things that cannot happen. If you walk, you should be able to feel it. And that's because the spinal cord is like an onion with a lot of layers. And the most important layers are inside, they are protected. And deep pain is the worst thing you can lose. And it's really in the inside. So if the animal can walk, we should not be testing nociception, because, or if the animal has movement, we should not be testing nociception, because nociception should be normal. Last but not least, that would be bonus tip number 11. That would be the differential diagnosis. When we do all the neuro exam, when we put all the parts together, we need to try to localize the lesion. And it's not easy to localize the lesion, but we need to try to understand, first, really simple. Is this a brain problem? Is this spinal cord problem? Is this a peripheral nervous system problem? Or if it's not any of these ones, if the neuro exam is normal and it's not a neurological problem, basically. When we manage to localize where the lesion is, then we will use the vitamin D, or the DAPNIT-B is the same. Usually in the UK and Europe in general, we use more the vitamin D, and in America, they use the DAPNIT-B, it's just the same in different orders, to try to understand where to localize the problem and which is our differential diagnosis. The main things to know it is history, if it's acute or chronic, course, if it's progressing or it's non-progressing, hyperesthesia, if it's painful or not, and if clinical signs are lateralized or not. You can find this table, and this is a table that it tries to explain very similar, the same that this graph that you will find in a lot of different books. But basically is that you should learn that, for example, vascular disease are really acute, are non-progressive, usually not painful, and usually really lateralized. So when we have, for example, an animal that is not painful, it's really simple and to think, okay, most likely vascular, yes. Is it going to be inflammatory infectious? Extremely unlikely. So with all the information that we have, together with the presentation and knowing the signalment, we will be able to do this vitamin D. So the conclusions of this webinar is do it. Do neuro exams, a lot of neuro exams, practice, stay there, try to do as much as you can. And if you don't know if the dog needs it or the animal needs it, just do it. The worst that can happen is that you do it and in a second you say, okay, that's fine. Like probably it's not a neurological problem. Second, the more you look, the more you see. And that's the example of when we examine the dog in the hands-off situation. With the hands-off, we could see, yes, mentation and behavior, posture and gait. But if you spend time, and for example, when an animal is in the consult, you take it off the lead and you leave them free while you are talking and while you are trying to understand why they are there, you can see the animal moving and you can see the animal interacting. And the more you do that, the more you will learn and the more subtle things you will see. More things, floor almost always. The neuro exam can be extremely different in the table than in the floor. Animals in the table get completely petrified. They don't move, they don't do anything, and everything's really, really bad. And a lot of times in the floor, they are much more comfortable. The exception would be cats, that cats usually are more comfortable in heights and they are more comfortable in the table. And really small breed dogs that may be more comfortable in the table. Less is more. The less you try to grab the animal or touch the animal. If you cannot touch the animal, take a trick, take something, try to move around, use the family to try to do things. And the less you try to restrain them, the more you will get. Don't test the pain nociception if not needed. And then the final tips, it's that you can see this presentation, it's full of videos, and I could have put like 10,000 videos more. And at the end of the day, if you don't know, record the video. It may be helpful for you to learn, to see it later, retrospectively, and to try to understand. And it will be really, really, really helpful to ask for help. We not always know the answer. We sometimes need to share it with colleagues from your practice, from friends, from vets, or even for us. And we in VetsCT are extremely, extremely looking forward and really, really grateful to be able to work with all of you and looking forward to help you and assist you with all the case possible. And as a specialist, we love to have this relationship with you and try to see as many videos as possible and ask for help. And you will see and you will learn when we look at these videos, all the information that you can get. And that was a little bit this first part of the webinar. So just to go to the most hot tips for the neurological examination. And if you have any questions, I will be delighted to try to answer all.
Thank you, Anna. That was amazing. Just so useful, actually, and really, 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 really practical. And I think I was nodding away to everything like that. I just thought, yeah, that's brilliant. What I loved about that as well, sorry, I'm going to hold the floor a little bit just while people think about questions, was that hands-off, hands-on approach as well, because I think the videos that you showed us as well show you the sort of videos that are so easy to get. And actually, we can help so much with the hands-off approach, and then we can advise people on the hands-on approach as well. Obviously, we can't be there in a clinic room with you, but we can help guide you as well. So I think just seeing those videos and seeing what type of videos and how to access your expertise is really, really, really useful. So I found that really useful as well. I hope everybody else did. Okay, so if anybody's got any questions, please do sort of put them in the Q&A, and they can range from anything really. So let's have a little look. I think so there's quite a few coming through. What is the significance of a tail jack test? I'm not necessarily familiar with that. Is that where you lift up the tail?
I'm not familiar either. I'm not sure if you don't mind to.
Yeah, Vishnu, I think just give a little bit of detail of that if you can in the Q&A. So yeah, we'll have a look at that. And what interpretations would you make if the proprioception reflexes are negative?
Yes, that's a really good one. There are two things that I need to say before. The proprioception is not a reflex. So a reflex is something that we do without thinking. So if someone puts fire on my hand, I would just remove the hand really, really fast, but I will not be thinking what I'm doing. And just after I did it, I would be like, oh my God, what just happened? A reflex is an information that goes from the paw or from the limb to the spinal cord. So in this case of fire would go to my neck, to my spinal cord, and it will come back. And that's a reflex. It's something that is not going to the brain. Later on, and even for us, it's really, really fast, then it will go to the brain. And then it's when we will be saying, oh, what has happened here? Oh, there was fire. So that would be a reflex. And for reflexes would be withdrawal, patellar, all of these ones. Proprioception is knowing how we have a part of our body without looking at that part of the body. So everyone that doesn't have like a spinal cord injury, if I ask you if your limbs or if your foot are crossed or are not crossed right now, you know the answer without watching at them. You know how your limbs are positioning right now without looking at it. And that's because your body is related with your brain, and then the brain goes down. So proprioception is an information that goes to the brain and integrates to your brain. The pathway, and now I'm going to answer the question, the pathway goes from the brain to the spinal cord and then goes goes down. When proprioception is negative, it means that something in this pathway is not working. Almost always, it will be a spinal cord lesion. And therefore, you will need to check reflexes to see if it's an upper motor neuron or a lower motor neuron, and try to localize a little bit better where the lesion is.
Right. Okay. And can you explain again just the difference between hyperesthesia with hyperalgesia?
Yes, hyperesthesia is so esthesia, it's something that is not painful, and algesia, it's something that it's painful. So hyperesthesia would be that's the back of a dog, and I'm pressing gently, and the animal reacts. If it reacts as I'm pressing gently, I was expecting for the animal not to react. That's what I was expecting. Therefore, this animal is responding to something that I was expecting not to respond. That's hyperesthesia. Hyperesthesia is responding, like an increased response to something that it's not painful. Hyperalgesia is an increased response to something that is painful. What it means, imagine that someone comes and punches me here in the arm. And then I'm like, oh my God, it's really, really painful. It's really, really painful. And then someone says like, well, that's it. It was painful, okay. And I need to cause some pain, but it's like, just stop here. It was not that painful. So the difference is that the first thing wasn't painful and wasn't meant to be painful, but the second was meant to be painful. In general, hyperalgesia is a term that we almost never will be using. So the correct term is hyperesthesia. The other one, you can almost forget about it.
Great. That's really good, actually. That's something I didn't know the difference between. Okay. Are there any resources that you know of with common presentation videos? I think videos and visualization of neurology is so important. Are there any that you know of off the top of your head?
Yes, there are many. So what I would say, there is a web page. So basically, there are many, and these ones are made by specialists in neurology in general. The easiest way is, I would say, that is Instagram, and you can find tons of specialists sharing videos on Instagram for free. So it's something that you can find really easily. There is a web page that it's called VET.CT. That is also from specialists in neurology that has like tons of videos. And there's another webpage that it's called Neuro. But what I would say is try to find a few specialists that you like and try to check if they have Instagram, because it's really likely that you are going to find a few things there.
Yeah. And what I would also say is just take a video and send it to us, and we'll give you a 100% very friendly and helpful answer, because it's very really
exactly. So like that would be more to but absolutely, like if you have like questions about a specific case, then send it to us 100%.
Can you give any quick small tips just for sort of nerve localization of spinal nerves? So I presume the cutaneous trunky sort of reflex.
So I think that probably it's more focusing about how to localize in the spinal cord.
Okay, yeah.
So the spinal cord really, really simple. You need to think what's the upper motor neuron and what's the lower motor neuron. The spinal cord is divided in 4 areas: C1 to C5, C6 to C2, T3L3, and L4S3. The first C1 and C5 and T3L3 are upper motor neuron lesions. And C6 to T2 and L4S3 are lower motor neuron lesions. In the upper motor neuron, we will see increased muscle tone and spinal reflexes. So if the forelimbs are affected and the spinal reflexes are increased, it will be C1 to C5. If just the pelvic limbs are affected, but the tone is increased, it would be T3L3. And then similar with decreased spinal reflexes and muscle tone. If all 4 limbs are affected, it's going to be C6T2. If not, it's going to be L4S3. But we can organize and try to organize like another webinar in the future about neurolocalization to give a little more tips.
Yeah, good idea. Thank you so much for a great lecture. Do you always localize head turn as a forebrain lesion?
It's a really good question. Until almost last year, the answer is yes. And almost all cases, the answer is yes. There is a nice paper out there that is access-free that I collaborated in the paper, but it's like a paper from multiple universities in the UK and different universities in the UK. And then basically in that paper, they try to see where do you localize with head turn, and there were some vestibular diseases too. But I would say that the majority of them still being forebrain.
Great. Okay, and another one on brain lesions. So what are the signs of brain lesions? Quite a big question, and how to localize them.
So the brain, like, again, is really big and have different parts, and these parts have different actions. Knowing and understanding the normal functions of each part of the brain is really important, because it's going to help you deciding when it's abnormal, which part is affected. But making it really, really simple. Forebrain is mentation and especially behavior. Forebrain are all of these things that we were seeing before. Behavior not being normal, head turn, head pressing, these kind of things. And really unlikely that gait is much affected. Brainstem, it's the most important part of the brain. It's the one that is more in the inside, it's the one that is hidden. And this part is the one that when we have real problems in the brain, then there is where the problem is. So are the animals with coma? Are the animals with not responding are the animals that are a real emergency. And then cerebellum is the responsible of coordination. So if I want to move my arm and touch my nose, that is possible because my cerebellum is working. If my cerebellum was not working, I would be moving and I wouldn't be able to find my nose. So usually cerebellum is the easiest to localize because there's a lot of tremors and there's a lot of incoordination.
Okay, that's great. And sort of similar with the back end of an animal, the lumbosacral disease syndrome, any tips around there as well?
So yes, lumbosacral syndrome, what is really important is that we need to understand that the spinal cord has finished. So the spinal cord finishes usually around L5 in dogs, a little bit more caudal in cats, but that means the vertebra. And lumbosacral is when we discuss about L7 is 1. And therefore, it's the very end that it's what we call caudequina. Lumbosacral syndrome usually are animals that really struggle to stand up, and usually are animals that they walk like really slowly and like really short-strided gait and a little bit stiff. Proprioception almost always is normal. And the reason why it's normal is because we are in the caudequina. It's like the really end. And therefore the spinal cord is not affected. But the spinal cord reflexes, the segmental reflexes are affected. And usually like they have pain. Hyperesthesia, as we learn. One of the things that is really important is that almost all old animals have a little bit of a lumbosacral syndrome. So we need to make sure that we not overdiagnose it. We need to make sure that when we diagnose it, that we really believe that that's the problem, and we need to make sure that there's nothing else going on. And apart, we just found that there's a little bit of pain in the lumbosacral area.
Right. Okay. And do you have any tips regarding neurological examination in animals with aniscoria?
Yes, anisocoria. It's when both pupils don't have the same size. So one is really big and the other one is really little. The responsibility of moving the pupil is the sympathetic and the parasympathetic system. So it's the autonomic system. The sympathetic is what we call fight or flight. So basically it's when we need to be alert and we need to be tense and do something. So what happens is that the pupil dilates. And the parasympathetic is what we call rest and digest. That is when you are really calm, it's Sunday, you don't want to be doing anything, and you don't need that amount of light. And therefore, the pupil goes really little, and like we just can see some meiosis. So to be able to examine the anisocoria, you need to do PLR, and you need to do the pupillary light reflexes in normal light and with the lights off. Because in normal lights, it's normal that we have kind of light and that's it. But imagine a dog or a cat that is stressed in the vet and you like turn the lights off. What the animal should be doing is that the pupil should be going really big. The pupil should need to dilate. Why? Because they want the light, because they want to see what's going around. Therefore, looking at the PLR with normal light and without light and seeing how the pupils are responding, it's what's going to tell you what is affected, if the sympathetic or the parasympathetic system.
That's great. And do you mind just defining the difference between ataxia and paresis again, just to give?
Ataxia is incoordination. So it means that it would be like a drunk animal. It's that when you are seeing the gait and the animal is like lifting the limb, you are not completely sure. You cannot predict completely where it will end up. You don't really know if the animal will do like this, or it will do like that, or it will go the other way. So it's an animal that we cannot predict exactly what's going to happen. It's incoordination. Like ataxia, incoordination are the same. Paresis is weakness. Is an animal that doesn't have the strength to do the full step. And then what we see usually is when they start scuffing, when they drag the limbs, or when they can like at the end, they cannot walk at all.
Okay. And again, just a similar one. Can you just define the upper motor neuron again and just how to differentiate them, just to be clear on that?
Yes. The upper motor neuron is a neuron that both the cell body and the whole axon is in the nervous system. So that means in the brain and in the spinal cord. And the lower motor neuron is a neuron that starts in the spinal cord, but goes to the limbs. The upper motor neuron, the lower motor neuron, I really like to explain it thinking about the kindergarten. The upper motor neuron is the teacher, and the lower motor neuron are all the kids in the kindergarten. What is the function of the upper motor neuron? Control the kids and tell to the kids what to do and organize the class. When we have a problem with the upper motor neuron, just imagine that kindergarten, that the teacher one day is sick and is not coming to the class, but no one knows it. And then you have, I don't know, 15 kids, 15 like there in the class. How is this class? Like, my God, it's really excited, the class. Like everyone would be shouting around, moving around, like there's a complete discontrol of the situation. Therefore, when we have an upper motor neuron problem, it cannot control the lower motor neuron. And what we have is everything excited. Therefore, reflexes are going to be increased and muscle tone is going to be really, really spastic. If we go to the opposite situation, all kids get sick. And then the teacher goes there and it's like, oh my God, there's no one in the class. What happens? Calm, complete calm. That will be the simile of having like decreased muscle tone and decreased or absent spinal reflexes.
Great, love that. It's a really good analogy. Okay. Maybe a tricky one to answer, but is there a surgical option for post-traumatic huge cavitary lesion in spinal cord?
Yeah, this one is a little bit difficult to answer without seeing the case. And for example, that would be a really good case for VetsCT basically, and sending us the images so that we can examine it together, not only neurologists, but also with the radiologist. The answer for surgical option in yes or no is yes. There are options of shunting the spinal cord and there are options like that. But what it would be really important here is understanding how the dog is. So it would be not the same if the dog is paraplegic, that we know that cannot move, deep pain positive, deep pain negative, or if the animal can walk. So like understanding a little bit more the patient rather than the images, it would be really, really important to answer this question.
That's great. And if you've got any good reference books for anybody on this call that for neurology that would explain neurology well?
There are two books that I would strongly recommend. Now in the market, there is a book that it's a typical thing that you don't even know the name of the book. The authors are Curtis Dewey and Ronaldo da Costa. It's a book that it's a little bit difficult. So that would be second level book, basically. If we go for first level book, what I would say is hold for now. And if you can, wait one more month. And there is a book that is BSAVA that, in fact, one of our neurologists, Elsa Beltran, is one of the editors, one of the main authors. This book, we've been waiting for it for a really long time because it's going to be really good and really brand new because the other one is a little bit old. So if you can, and if you don't mind, I would say wait one more month and we will have a really, really nice brand new book, and definitely the one that I recommend to start learning neurology.
That's great. Yeah, fantastic. And we've just got another couple of questions through a different route, but what happens if you have a very aggressive dog? Where would you start? And maybe this would be your hands-on, hands-off approach?
Yes, exactly. So for example, if we have a really aggressive dog, first of all, safety. Safety for everyone, safety for the family and safety for yourself. And it would be two options, like a really aggressive dog with everyone, or a really aggressive dog with the vet, but with the client is like, it's doing fantastic. Hands off, extremely important. listen what they need to tell you, listen why the dog is there, and try to see what happens. With really aggressive dogs, what it's life-changing is if they are food-oriented or not. If they are food-oriented, life makes easier. And then what I try is to leave some tricks in the floor, like without even touching the animal, just leaving to them or giving it to the families, and then the families giving it to them, but they can see that it's coming from my side. And then I try to do as much as I can without touching the animal. If I can't touch the animal, I don't touch it. I see what happens with like gait and what happens with cranial nerves, moving tricks and moving things around, but safety first.
Right. And I think we've got one last question just related to the eyes as well for Kirsty. She had a cat in today with bilateral mydriasis, which is where you have dilation of the pupil, isn't it, I think? And it's very difficult to assess if there was anoscoria, if there was any anisocoria, sorry, if there's any difference. Are there any tips to get around that if you've got sort of that presentation?
There are a few things. In the consult room, again, turning the light off. Because when you turn the light off, usually things get more evident because you are forcing this sympathetic system to dilate the pupils. And therefore, it will help you to see if there are differences between one thing or the other one. If you are not sure, it's true that cats can be really frightened in the consult room and they may be really dilated, but it's not a real problem. If it's not urgent, what I would say is ask to the families for pictures or videos at home and try to say, oh, look, the pupils here are really dilated, but it could be just for stress. I would recommend that when you go home, you try to check it and see if you think that both pupils are the same size or not. And I would just be really honest with them.
That's great. And actually one last one, because it's related to the aggressive dog, and actually it's a very valid question around drugs and does that affect neurological exam. This one was particularly around, is it possible to give something like gabapentin to control the behavior of aggressive dogs? And does it affect the examination? And how should we interpret neurological examination, I suppose, in relation to medical sedatives or tranquilizers?
Yes. I would say that this is an answer that probably, like, it's the one that it will be more clinician dependent. And probably each clinician will tell you different things. My personal opinion as a clinician is that the animal goes first. The animal goes first in the testing. The animal goes first on my examination. The animal goes first on the testing. The animal, it's what is important. So what I mean is, if the animal is really aggressive and we need to give gabapentin to control the behavior, just give it. I will try to see how I fix it later, or I will try to see if it really affects me or not. But yes, absolutely, you can give gabapentin for control of behavior. It is true that if the animal is really sedated, we may not be able to do a full neurological exam. So we need to be careful on how sedated the animal is before, or see if the animal has ever had gabapentin before. Using this question, very similar in terms of pain. Personally, I don't like having like any of my patients on pain. So like, I don't mind if they send me the animals with tons of analgesia. Like, I don't mind. I know and I understand when that happens that the information may be a little bit different. And I know that I may need to interpret things with caution. And then I'm really honest with the families. And I said, look, I'm just going to assess pain. It may not be exactly really reliable or 100% reliable because it's on a lot of meds, but I just wanted to make sure that your animal was comfortable. So absolutely no problem for giving gabapentin like before a consult.
Right, really good. Okay, I mean, this has been brilliant. It's been really, really good. It's very, very useful. I think you can see from the questions as well that there's loads of questions. So I think we've got one more slide, which I just want to talk about, if you just don't mind moving it on, if you can. Okay, so we've got a series of more webinars coming up every second Tuesday at 7 p.m. And the next one's coming up, we'd love everybody to join if we can. So the next one, sorry, I'm just looking at my, we've got, in 2 weeks' time, we've got cardiology, how to record and interpret an ECG, which again will be really practically based talk for people there. And then we've got Daniel Sanchez as well, another one of our 9 neurologists at VetsCT, and Danny's absolutely great. And we're going to be talking about managing the difficult epileptic, so seizure management in that. And then 2 weeks after that, we've got Chris Byers, who's double boarded in internal medicine and ECC, an American specialist. And he's going to be talking about localizing dyspnea. And then the final talk just of this series until the second half of the year is going to be a really, really interesting one as well with Juan Carlos, one of our oncologists, talking about quality of life of dogs with cancer and how to sort of think about that in an oncological perspective as well. So just from a neurology point of view, I think we've just seen use videos, use multimedia. The videos are really good quality. We've got 9 neurologists here at VetsCT. You can access us through written advice, text chat, which is an asynchronous way of working throughout the day, so you can access our neurologists that way if you're working. You can book appointments, you can book callbacks. So we're fully accessible, and we'd love to see your cases and help you with those cases. If you want to register for more webinars, please scan that link. If you want to have any more info on how to access specialist case advice, please feel free to email me directly as well. But Anna, thank you very much. It's been really, really good. And I've certainly learned a lot as well. So thank you so much for your time. And thank you everybody else for your time as well. It's great.
Thank you so much. And it's been lovely to be here with you this night.
Great.